and we're going to be doing the emergency nursing module for lecture module 2. We're going to start off by letting you know that this is in conjunction with your reading list. So everything in our lecture material will be resources to you, and all of the adjunct materials that you have on the side to read, watch in CoursePoint Plus will also be helping you in this area. Just a little bit about myself. I was a ER nurse for 13 years, so I have a lot of experience in this area, and it's one of my favorite near and dear specialties in nursing, so hopefully we'll enjoy the ride. Learning objectives for this plan, this lesson plan, are to describe emergency care versus med-surg, oncology, things like that. Emergency nursing is a specialty in itself, and we'll go into the differences between the two. Understand priority emergency interventions for patients in emergency situations, whether it's a motor vehicle accident, a trauma of some sort, falling from a high level, and injuries such as that. Identify the priorities of care for patients that have multiple system injuries. It's really important to understand how to care for each and every one of them. Specifically, the similarities between the emergency management of swallowed or inhaled poisons, skin contaminants, food poisoning. Understand the emergency management of patients that have drug overdoses. If you are planning on working in the emergency room, this is very, very true to what you will see in the emergency room. There's a lot of acute alcohol intoxication, and you need to understand how to care for those types of patients. Sexual assault victims, there's special protocols that need to be done for those types of patients. Overactive or violent patients, and depressed and suicidal patients. Scope of practice for emergency nursing includes the management of what was traditionally referred to as urgent care, critical care needs, but the emergency room has changed and morphed because of the need for primary care and treatment, so it really includes whatever definition of patient or family considers it to be. The emergency nurse has special training, education, experience, and expertise. Myself, I had 6 months of critical care classes, trauma training, and those kinds of things in order to learn how to become an emergency room nurse. They don't just throw you in there, so be prepared to have a long orientation, because it's a very skilled specialty and you have to get to know everything. The emergency department is a team of players, and it's actually very, very cohesive. If any of you have had experience in the emergency room, there's a lot of communication that happens in the team membership between the doctor, the patient care technicians, the RN, the primary RN, and the RNs that are working around. If there's ever a person that's actually needing more attention than another, usually nurses from another team might run over and help you. So you're never alone in the emergency room, which is awesome when you're working in nursing. The scope of practice we already went over. Legal issues. You're going to learn a little bit about legal issues that will come up when you're working in the ER. Occupational health and safety risks. We all signed the form that we know that we're going to be exposed to possible outside things like viruses, chemicals, things that can come in, radioactive materials at some points. We'll talk about those moving forward. The challenge of providing holistic care in the context of the ER is really fast-paced environment. So a lot of time we're taught in med-surg to take our time doing a head-to-toe assessment and spend time with patients. Unfortunately, in the emergency room, you really don't have a lot of time to spend one-on-one with patients for extended amount of times for teaching and that kind of thing. So you really learn how to hone your assessment skills. They always recommended that you get at least a year of med-surg under your belt before you try to learn in such an environment. But there are people that learn well in a fast-paced environment. So if you're one of those, emergency would be a good specialty for you. I personally took 3 years on med-surg oncology before I went to the emergency room, and it really helped me to be able to be comfortable with my assessments and get in and know what I was doing. If you go in right away, sometimes you don't have that time to learn assessment and understand different disease processes that come through. Like I said before, treating patients that are exposed to biological and weapons. I haven't seen a lot of that in my experience, but it has happened, and we'll go over that kind of thing here in this lecture and with the following lecture. Mass casualty incidents due to natural causes or terroristic event. Again, that really hasn't happened for me, but we have to be ready for something like that to happen, because places like New York, Chicago, bigger cities that tend to have things like that, you never know, you may end up working in places like that. Priority emergency measures for patients. I want you to understand that safety is the first priority. We as nurses and healthcare people tend to just try to be heroes. You got to remember that trying to be a hero all the time can actually put your life in danger. So please, please, please assess the situation, and if it is a dangerous situation to be in, then you need to get out of it. For example, I had a patient that I was triaging who came in. He was high on a speedball and heroin, and he sat in my chair telling me that he was suicidal and homicidal. He was rocking back and forth, and his pupils were dilated, and he really was scary looking. And I stayed calm, but I had a sense that something was up with this guy and that he could crack at any moment. So I asked him what was going on, and he said he really wanted to kill someone, and he looked straight in my eyes, and he was rocking back and forth, and I'm thinking, okay, stay calm. Don't rile him up. I said, okay. And I stood up very slowly, walked over to the phone, talked to my charge nurse, told her to call security, because I knew that there was something off on this guy. So you got to listen to your instincts. Turns out the guy had a pocket knife in his right hand under the table that I didn't know he had, and he could have come right across the table at me. So it's sometimes how you deal with situations. You make sure that you're not in a situation where you're unsafe. Make sure that you listen to your gut and get out of there. It's not worth it. You want to go home to your family. Sentinel events in the emergency room can delay care. Delay of care and medication errors can be sentinel events. That's why it's really important for all of us to really know what kind of medications we're giving, which ones we're allowed to give, which ones we're not allowed to give. So it's really important to focus on that. Patient and family focused interventions. These are actions to relieve anxiety for not only the patient, but the patient's family, because you want to give them a sense of security that they can trust you. I was talking to my clinical group yesterday, and we talked about just the introduction going into a room. You make sure that you talk to the patient and let them know who you are, what you're going to be doing with them, and that helps to relieve anxiety. And also asking them questions about what they are expecting from us. At this particular time, there's not family allowed at the bedside because of the COVID-19, but as much as possible, especially with elderly, I know at St. Joe's they were letting patients that were over 65 have a caregiver or a family member at the bedside, because a lot of patients over 65 either are confused, have dementia, or really just don't know their health history, and it's really nice to have family that can do that. Otherwise, we'll just call them on the phone, but the family member can keep the person calm. Now, there's times where a family member actually makes the person worse. So that is when you have to use your judgment and whether or not they need to stay there with them. That goes everywhere in the hospital. Again, we want to be clear and give clear expectations and information, but we also want to ask if they have any questions for us. We need to let them know what's going on because they have no control over what's happening. Principles of emergency care in the triage department. Triage actually comes from an old French word meaning to sort. It may be French or Latin, I can't remember, but that was the word that I learned a long time ago. Triage sorts the patients in the hierarchy based on the severity of their issues coming in the hospital. When we go further on, I'll talk about the scale that we actually use in the hospital. Triage nurse collects the data and classifies the injuries and illness according to where they need to go in the emergency room, whether they're a lower level of care to the highest level of care. Protocols can be initiated up in triage. Triage is usually a room up at the front of the hospital where people check in, and that's where the nurse greets the patient and can make the assessment on whether they're urgent right now or they can wait a little bit to get a room. Some places like Northwest Medical Center has an ER over on the east side that has a respiratory therapist that's up in the front in the triage that actually does some of the triaging. The ED that goes with the ED triage differing from disaster triage with patients who are almost critically ill to receive the most resources regardless of the potential outcome. So that just means we just got to get them back and get them treated. So this is what I was talking about a minute ago. There's a basic system, 3 categories. Emergent is the highest priority. Urgent, of course, is a serious health problem but not life-threatening. And then non-urgent patients, episodic illnesses that just come like a cold or maybe a rash that started up. Those kind of things are non-urgent. In every hospital that I have worked at, Northwest, TMC, and most of the hospitals in Tucson, Carondelet, use the emergency severity index to assign patients to 5 levels. 1 is the most urgent and 5 is the least urgent. So the primary survey is the one that the triage nurse in the first assessment when the person comes through the door in the emergency room, they focus on stabilizing life-threatening conditions. Of course, it's airway, breathing, circulation, and on this code, it's disability or exposure. So airway, breathing, circulation, the ABCs are what we're looking at. For instance, when you have a patient come in through the triager, you're assessing them as soon as they walk in the door. You're looking at skin color. How are they breathing? Are they cognizant? Do they know what's going on around them? Who's with them? And you're making assessments very quickly. Again, that's where experience in assessments is really important. Disability is, again, what we were talking about, the neurologic status. So we went through airway, breathing, circulation is, you can see the color of their skin. You can tell right away if they're not looking good. And you set them down in the chair. Disability, again, is the cognitive thing, or whether or not they have the ability to walk, explain, let us know what's going on. Exposure is if they have been in an explosion or if they had some kind of chemical spill, we need to undress them. If they're in a trauma, they need to be completely undressed so that we can see every part of their body. Now, those patients that we do that to is not necessarily done in triage area in the hospital when someone just walks in. This is more applicable to those patients that come in by ambulance and we need to get them assessed. Not to say that traumas don't just get walked in. When I was working at St. Mary's Hospital, we had a lot of gunshot wounds that came in just got dropped off right by the door. It was very sad. It's gone down a lot, but it did happen. One time a gentleman was being carried in by his friends, and we didn't know what was going on. He said he got shot, and we, immediately when I was a brand new ER nurse, I got on it. I was like, okay, I got to cut off all the clothes. I got to find out what's going on. Got him on the stretcher, cut off all his clothes, put everything, just trying to find out where this gunshot wound was. We assessed his backside, and on his bottom there was a skim of a bullet that went by. We finally got down to his feet, took his shoes off. It was his big toe of his right foot that got shot. Not that that's not traumatic, but it made us feel better that it was just his toe. He was screaming bloody murder. We thought, oh my gosh, he must have got shot bad, and then it was the big toe. So, but we had to take off all his clothes just to figure out where it was coming from. So secondary survey is the health history, where a lot of times the physician comes in at this point. If it's a triage patient, they'll sit down with the patient. What's your health history? Head-to-toe assessment. All of those things start happening when the physician sees the patient. So there's a head-to-toe assessment, reassessing airway. All of this stuff is a lot of times done in groups, like we talked about, the team approach. The RN is in the room doing the same thing the doctor's doing. Diagnostic testing, lab testing, usually as an ER nurse, depending on the ESI level, the emergency status level. If they're like a 2, 3, and they got back to a room, we're going to start, we'll say that they had abdominal pain. We're going to start an IV. We're going to get fluids going. We're going to draw labs. If it's a cardiac in nature, we're going to start doing EKG. If their blood pressure is super low and we have to start monitoring them very closely, we'll put an art line in. Actually, that's a physician's job to put an art line in. Put a catheter in to get a urine sample to see what's going on. Again, this is all based on the level a person is awake, conscious. Literally, if a person comes in unconscious, we have to do everything for them to find out what's going on. If we know that it's a trauma, the person broke a leg and it's a very obvious misplaced fracture, there's a deformity of the leg, arm, extremity, we're going to splint the fracture after we get x-rays done. Wound care, if there's a wound, a gash that happened from, I don't know, a tree falling down on a patient's leg, someone was stabbed, that kind of thing, we have to intervene quickly. Other interventions are based on the patient's condition. Other priority emergency measures are if there's an airway obstruction, establishing ventilation and getting an airway in is important. We're going to talk about that going forward. Oropharyngeal and nasopharyngeal airway insertion is important when you can't get through the airway. We have to bag them. For instance, if an oropharyngeal airway is used, and there's a good picture on page 2164 of your textbook, a chart 72.3. It shows how to put in an OPA, is what we call it, oropharyngeal airway, and then the nasopharyngeal airway. So the difference between the two is the oropharyngeal is when someone's obtunded. When we say obtunded, we mean they are either sedated from heroin overdose, medication overdose of some sort, some kind of brain trauma, or maybe they're intoxicated to where they're not holding their airway. We often use the oral airway in the OR for after they come out of sedation. So the oral airway is for those types of situations where we can bag the patient and get airway through the obstruction, usually the tongue falling back. Nasopharyngeal airway is sometimes used for obtunded patients that have an airway that they're snoring, again, like the tongue is falling to the back of the throat, and it can be inserted to kind of bypass the tongue and get an airway back there. We all should know about endotracheal intubation. I have on my next slide, I'll show a picture of that. There's king tube or laryngeal mask. I call it an LMA, cricoidotomy, and we're going to go over that, and ventilation. So you're going to see this on Christina's slide as well, endotracheal intubation. It shows the, we call it ET tube. There's the laryngoscope, and here's the tube that they put down. This one goes right down the airway past the epiglottis and the vocal cords. Now here's the King tube. I have to say I really haven't seen a lot of this type of tube. I know that EMS or paramedics tend to use these a lot, but we don't use them typically in the hospital. Usually it's between the King tube and, on my next slide, the LMA, which is it's a mask that kind of goes over the airway but blocks off the esophagus, and it tends to be like the temporary sedation thing. This is not used for long-term. It's used for short-term things like surgeries or and getting the patient to the hospital. Some of the EMS workers will use these. Sometimes emergency doctors will use them depending on what we need it used for, but it is a temporary mask, the LMA.